English Premier League kicks off literally into action, and you don't have to go too far away from here because the Standard Group has all the exclusive broadcast rights to make sure that every goal, every penalty, every decision, every VAR look into all the action is taken right here. Radio Maisha and Birur FM with all the information for you and all those up to the minute data analysis information and all the goals, every decision, everything about the EPL coming right to you, so you don't have to go too far. Right. Walter Kinjo will be there making that commentary for sure. So as it kicks off today, you have all the information and everything and all the action coming to you directly right here from Standard Group across all our platforms, TV, radio and digital. So you want to get into it today. Sawa? Yes.
Kapisa.
All right. So we're getting into our final conversation for the week. And over the last couple of maybe 3 days ago, there was a health summit that was held in Nairobi. And we're looking at how SHA has been working and the president was His Excellency the President was involved in this process with the practitioners from SHA. They're letting us know how things have worked and how things are being paid. That's fantastic, I say. And you have to look at all of this in the context of the situations that we deal with. The Kenyatta National Hospital sent out a circular yesterday, and they basically said, guys, unless it's an emergency, do not come. That's basically what the CEO of K&H said. Why? Because we don't have hands. Because people are on strike. He stated this very clearly yesterday. And let me just read his statement before I welcome our guests into the studio this morning. Okay, where is that? Real quick. This is what the letter from K&H said. And it has disappeared. But anyway, I'll read that at some point. First of all, let's welcome our guests to do the CEO and SG of the Kenya Medical Dentists Practitioners Union is Dr. Davji Atellah, and he's here with us this morning. Good morning, Dr.
Good morning, Drew.
How are you doing?
I'm doing fine. How are you?
Very well, thank you. Karibu.
Asante.
The Secretary General, the chairperson of the Kenya Union of Clinical Officers is Peterson Moshera. He's here with us this morning as well. Good morning.
Good morning.
How are you?
I'm well.
You are?
I hope we had to.
We're working on it. We're working on it. Karibu both. We're getting into this. Before we do, let's start off with today's proverb. This one might be interesting.
The proverb comes from Mauritius, country of 1.3 million people, an island country, tourism, good, manufacturing, working, and also considered to be a financial hub. The proverb, a short person hangs his bag where his hands can reach. How would you interpret it, Davji?
Yeah, it just basically correlates with the proverb that says that you should cut your coat according to your size, that you should basically live within your means, and basically that actually implies to that when you budget, when you plan, do with whatever abilities that you have. Don't depend on an external support on the matter.
Ashira, how would you interpret it?
I think similarly I would say that it talks about understanding your capacity, know your reach, and have the wisdom to know where your capacity cannot take you, so that then you don't waste a lot of time trying to do what you can't be able to achieve, and you concentrate on what you can. Yeah.
Well said, well interpreted, Asante.
So the health summit took place in Nairobi a couple of days ago, and all the practitioners, stakeholders, both of you were there at some point during the summit, and all of this happened when essentially the health sector got a clean bill of health in terms of how things are actually going. Yesterday, this letter came from the Kenyatta National Hospital, August 20th, 2024, and this is from Dr. Richard 2026, good Lord. I saw 4 somewhere. 2026, I beg your pardon. Dr. Richard Lesiampe, who is the CEO of the Kenyatta National Hospital, said, Kenyatta National Hospital is experiencing increased patient volumes and congestion following industrial action affecting health services in various counties. As a national referral hospital, KNH is receiving more patients who would ordinarily access services at county and other health facilities. This has resulted in longer waiting times and delays for non-emergency services. Clients seeking non-emergency care are encouraged to consider other hospitals closer to them where appropriate, to ease pressure on KNH and to facilitate timely access to care. KNH remains open and continues to provide emergency and critical care services. We regret the inconvenience and appreciate our clients' patience and understanding, signed by the CEO. These two scenarios are operating within the same space. We'll start with you, Dr. Atellah. Having come from the Health Summit, it just seems a little bit strange that this is happening at the same time. Mind you, the Health Summit was taking place when folks like Kuko and the Nurses Council and the Nurses Union across board are on strike.
I don't think there are two scenarios. I see a single scenario.
It's the same thing, okay.
It's a single scenario. We are all Kenyans in this particular context. And I believe, and it's a reality, that the Health Summit was a point of conversation and a point of dialogue where everybody were able to come up and bring these matters. The Council of Governors were there seated. Mm-hmm. The President was there seated. The ministers were there. And the Kenyans were watching. Mm-hmm. So it is a clarity to at a point that through this summit, these matters came out. Okay. And therefore there were commitments for things to be resolved. So it will not be right to say that we should only have the summit when there are no issues, because the issues are there. And they're still going to be there. Mm-hmm. Yeah, they're going to have a position to resolve them, but then continue to be there. So I believe these conversations that were there at that point brought out why the interests, why things are not moving. And that's why the unions were asking the intervention of the head of state in some of the engagement that are ongoing. And I remember the strike that has been there for more than, I think, 3 weeks now for the nurses. There was a commitment from the Chair Council of Governors that they'll be meeting today to give a counter offer to the nurses to have these matters resolved. So I believe that is the reality. So we must actually face the problems with whatever the level it is so that they can be resolved. Otherwise, if we will have not had the summit to discuss the matters, then we will be having those boardroom discussions where you wonder what was discussed. But this came out, and so we expect a commitment and a result, a commitment from the government that they're actually going to resolve the matter that is existing with the nurses strike, where the CBAs have already been done from 2017, where the agreements have already been honored. On the side of this letter from SHA or KNH, is a clear indication that the truth is when hospitals, the level 2s, 3s, and 4s, and 5s in the counties are not operationalized because of the strike, it means that everybody is seeking refuge at KNH. And the KNH is running at the same capacity. So it's a clear thing that they're trying to say that they just need to handle emergencies. Because you will go at KNH, and if it's not emergency, it will take a longer time to actually see a doctor. And not because the healthcare worker doesn't want to see you, but because they're actually handling other crises. That's the reason. So that's why they need the most urgent thing to be done for the country is to see that there's an end to the strike that is ongoing. Yeah.
Have we seen a change, Peterson, after this? Because if the Health Summit was then in place to address issues, it doesn't sound like it's an immediate thing. Rightly said, some of these CBAs have been in effect since 2017. That's almost 10 years ago, right? And we still see the same problems every year since there have been a CBA. Every year since there has been a CBA in the for the health practitioners, there has been a strike, if not a threat of one. That is terrible. Every single year, count it, 2017, 2018, until now, here we are. There has been a strike or a threat of one because of the fact that the CBA requirements and stipulations have not been adhered to. And there have been people, Dr. Atellah, you've been here. Every time there's been one, we've had a conversation. Right? Yep. So if the summit was to address some of these things, and I think it was great that the summit took place because a lot of things came out as a result of that, and that there was a hands-on approach, I think is even a greater thing. But will we see now the requisite action? Because the problem that we're seeing here is with this particular strike primarily is at the counties, and the representatives were there. What is it going to take for a CBA 9 years old to then be effected so that people can go back to work?
Thank you, Ndu. And I think we must give credit where it's due, as you have said. The summit is a good thing. And I think it was clear from its objective that the main summit was supposed to communicate about the government reforms in healthcare. So that is what they were doing. But we also had the presidential town halls, which now are discussing the salient issues that are affecting we as the health workers. And I'm saying we must give credit where it's due, because this is the first president we are seeing sitting with Kenyans, with unions, with everybody in the same room and saying, can we discuss these things? And it was a very good opportunity for a SWOT analysis of our healthcare. And I think we discussed, especially during the second one, we had a very great opportunity to discuss about these issues. We have immediate challenges, and we have challenges that will require a long-term solution. And I think the president directed on some of the immediate solutions. He said within 1 week, they should have resolved the issue of the UHC. By the way, that is a very simple issue, because it's only the letters pending. They're being paid at the rates of SRC. Their pay slips reflect the PNP status. It's just a letter. So, and he said, if after 1 week the governors will not have given the letters, then the letters will be given by the ministry. If that happens, that issue will be resolved. On the issue of the strike for both the nurses and ourselves, he also said that he was going to convene the governors so that they can see a way out of that. But then we have some long-term solution that we need. And you know, and as I said then in that town hall, we have seen bold and deliberate reforms. I think how it's working, it depends on who you're asking. And we have seen on the side of financing, we have seen SHA, we have seen FIF that ensures that facilities have money to be able to restock. When it comes to SHA, if you go to level 4 to 6, you will not have a problem. But where we are having an issue is at the primary healthcare level. And the problem is because it's funded by the Exchequer, and the Exchequer has not been able to fund it to where it's supposed to be. I think the actuaries were expecting around 50 billion. I think the highest we have done in this budget is 19.1 billion.
Hold.
Yes.
So where you as Kenyans have paid, or it has been deducted from you, the services are working. Let's simplify that, isn't it?
Yes.
Where the money is supposed to come from government directly, Exchequer,
yes,
is where it is not working, primary healthcare.
Yes.
All right.
And so, and I had an opportunity to speak with Dr. Ishenga of RUFA, and he was informing me that the PHC fund has not paid, I think, since April. So we must acknowledge that there is a problem, and probably Parliament going forward needs to see how to improve on the PHC fund, because it's funded by the Exchequer, so that it doesn't then take the money that we are contributing that is supposed to be for level 4 to 6. So on the financing, there are reforms. Are they working? It depends on yourself as a person, and also the level that you're going to. At some point, I had a relative who has had now 3 heart surgeries in a period of 30 years. The other one was in 2017, and NHIF then gave us around 450,000. The other one was last year, actually this year, sorry. And SHA gave us 950, which was an increment of 500,000. So if you ask my family based on that, SHA is working. We got 500,000 more.
Well,
so, but you can see that is the shift. It is between the level 4 and 6.
Where Kenyans are paying.
Yes, and that's why I'm saying that financing is sorted. When it comes to supply of medicines, it's sorted. KEMSA is now supplying more than 91%.
Yeah.
When it comes to the issue of information and technology, the DHA, when it comes to the equipments, we have that arrangement. But we have not seen bold and deliberate reforms when it comes to the human resources for health. And that is why we have been asking, can we now see, because we have sorted the other components of healthcare, can we now sort the human resources for health by bringing in a unified system that can be able to manage the HRH? Because it's very clear that the weakest link in the UHC is the ineffective management of HRH.
But before I just forget this line of thought, I think there's a part of which my brother is I think mixing here. We have the level 2, 3, and 4, the primary component of it of SHA, that actually where the patient goes to the facilities to seek the care.
Yes.
The SHA actually approves that you get the care. As a patient, when you go to the hospital, you are not going to feel any challenges to access this care. So whether you're in level 2, 3, or 4, and 5 and 6, based on the benefit packages that are already prescribed, if you go to seek the care, you will actually be, it will be approved for you to seek the care.
Okay.
Now, what probably as discussed with Leshenga is on the part of the payments of
being remitted to the facilities.
The payments that are being remitted to facilities.
Okay.
That's now dependent on, there's a part, I don't know what method the SHA uses, but then they paid differently or different times. So basically what is saying is the rate of payments of the debts may differ, but then the access, or rather the approval of the patients when they go to the hospitals is not hampered by this.
So primary healthcare, you will go to a medical facility, 2, 3, 4, you will get treated.
Yes.
The pain point here is after that, the reimbursement to the medical facility, who essentially gives you treatment on credit.
Yes.
Right? Is where the issue is.
Which now we've come to a point that we come to realize there is the generalization of this. You'll talk to one hospital today and they tell you they have their debts, and then there's a roll-off payment that particular month, of which when you ask the next day, that payment is done. So it's very difficult to generalize, and this is a reality. Generalize as like all this have not been paid, and that's why it has been difficult to have a single actions on it, because payments are based on an individual facility's claim. But that are done.
Go.
I think so that we don't lose Kenyans' thought. A lot of people don't agree with your submissions on the functionality of our healthcare ecosystem, including the human resource. I mean, even by your own admission, you're saying you don't know what methodology or formula SHA uses to make payment. And as a participant in that ecosystem, you ought to know, in a manner of speaking, because it should be a system that we all understand how it operates, how it functions, the entry points, both in terms of equipment, human resource, and the service provision of it all. Now, we could argue that, yes, maybe this regime is doing so much on health, but also the same argument is that a lot has been invested. We started this investment on the SHA and the SHIF to make sure that we transition to a more transparent, easily manageable, more accountable, and easily accessible healthcare for Kenyans. 2-3 years later, the struggle continues. Unfortunately, this is happening at the expense of losing life and people having conditions that are exacerbating by the day because they are not able to access the quality care that they so much deserve. I think we can all agree on that one. So the question then becomes, even as we try to balance the human resource, the actual resources, the facilities, because a lot of construction is happening. You find dispensaries, level 2, 3, 4 hospitals coming up. But service access remains a major concern, either limited by distance, which people are trying to shorten by construction, or limited by personnel being very few. And others now who should be working are out in the street. Today, what is wrong with our healthcare such that it is taking a president or a summit for us to convene, and even a president to threaten the governors that if you do not confirm these people to be PNPs, we are going to do it, which is unconstitutional, because health is a devolved function. If you were to call it today, what is the problem? What is ailing our healthcare system that if we addressed it appropriately, then at least in the next 3, 4, 5, 6 years, months, KNH and other facilities will not be overburdened. They're not issue disclaimer letters telling people to keep off, yet they're sick.
My brother, the entire problem about healthcare is money.
Yep.
Okay.
You get the point. If money is allocated enough, we will not be having the strikes for the for payments of the CBAs and return to be sorted out. When we have enough money that is budgeted for the primary health care, because it used to be 9, now it's 19. If it goes to the 50, as my brother is saying, that it means that payments will be done within the stipulated timelines in the Act. Within the 90 days, every facility will be getting their payments exactly as it is. So there will be no that complaint on it. If the money is enough, because I think currently, Kempidu in 2023, we were the union that went to court to stop SHA and the other acts at that time. Yeah. And then through the court processes, I think it was rolled out. There are big challenges at the point. In fact, if you look at the package on the oncology at that time was less than 400,000, which now is at 800,000. And through these lobby, and that's what we keep on saying, one thing we must accept, first of all, that we have the insurance, social insurance, and we must be in that insurance, and then now change it. Currently, we have Professor Jaoko, who is the chairman of the benefit and package, and we keep on insisting that these packages need to be increased, because it's through that increase in those packages that we can get the covers that are needed by the people. And that needs money. So yes, I agree with what Peterson is saying. We need more money in the Social Health Authority, and we need more members to subscribe, and therefore we need increase on the package continuously, which has actually been done. If you compare, because most of the time, and what we're trying to say, that it is much easier to objectively look at what is the issue, and then you bring out and tell the minister, tell the Social Health Authority, tell the people, this is what is not working, this is what need to change. Like when we had the issue of oncology, it used to be about 600,000 in NHIF for households, but then it reduced, and we had cases where people had to top up once that had ended. So we asked this needs to change. It was increased to 800. The same with ICUs. So we need to go with issues to try to change this. But when we come and say it's not working in totality, we become dishonest.
I hear what you're saying, Dr. Hari, but as we talk, Peterson, the issue of reimbursement to hospitals has been a thorny issue, whether we like it or not.
That's true.
And with that, then you'd find that Kenyans will go to seek services because that debt has not been paid. Hospitals will tell you, unfortunately, we will not accept using SHA. You have to dig in from the pocket. And at that point, a Kenyan who's gone to seek services would come out and say, SHA is not working. Why? Because they have been told to dig from the pocket. That is just pure. It happened to me. I am stating as a person who went through that system. So conversation ought to be then, where are the challenges in reimbursing these institutions, and how can we fast track it to ensure that when I next go to hospital, I'm able to be told, bring your SHA card, it will work for you. But then there is what the Health Summit said. But Wananchi down are saying, it is not working for us. How do we marry that and say, and bring a conversation where Wananchi are satisfied that what government is telling them is the truth?
True. You see, and to my brother Davji, I'm not saying that it's not entirely working. What I'm saying is that if I have a facility and I've not been paid for the past 3-4 months, then I might tell you that the system is down, because I don't want to take more credit. And that is what many facilities are doing. One of the private facilities that I take my family to used to tell us that they are no longer using SHA for some time. And I confirmed from SHA itself that they were actually accredited and they were supposed to be offering those services. And they were saying that because they had debt that had not been paid. So, you see, for us to be able to change a system, we must also look at it very objectively, and we do positive criticism. And I think we must keep saying that Parliament, because it's Parliament that budgets, Parliament that must ensure that we are having at least enough money, one, for the financing through SHA, And also, we must reach a point where we have very deliberate efforts to have annual employment of health workers. We do not only have an issue with the effective management of health workers, but we also have a dire shortage that actually threatens the achievement of the UHC. But then there is a legal and policy ecosystem that is also prohibitive. And that is why we are saying if we continue subjecting health workers to the current legal and policy framework, we may not be able to get somewhere. And to be clear, what I'm trying to say is most of the counties are not even doing beyond 60% of the staffing norms and standards that is required at the minimum. But when you go to their wages, they will tell you that our wages are past the 35% ceiling as per the PFM Act. Some will tell you we are at 60%. Yet on the other hand, they are telling you we don't have enough health workers. And so we must have a conversation, because then if today, let's say the president was to say, Parliament, please allocate 10 billion to hire health workers. If that money goes into the equitable share, first it's going to be subjected to that formula. The moment it gets to that county, 30 must be for development, 70 must be for recurrent, and out of the 7 for recurrent, only 35 is for wages. So if you were to take that 10 billion, less than 3 billion will be available to actually hire that healthcare worker. And that is why we are saying, can we remove this human resource from this confusion of this prohibition of the legal framework, get a separate entity. And I think we are proposing either Health Service Commission or a joint authority under Article 189, so that if you give that authority or that entity 10 billion, the entire 10 billion is going to be available to hire these health workers.
I'm hearing you speak about the Health Commission. So if a commission to handle HR issues for healthcare workers is in place today, are you then confirming or rather stating that would be part of solution to the problems you see today?
Yeah, and actually what I'm saying that even a commission might take us longer because we may need a referendum. But I keep on saying that we actually can have an entity without going through a referendum. If you look at Article 189 of the Constitution, it provides that in performance of their functions, the counties with the national government, they can cooperate. And in their cooperation, they can establish joint committees or joint authorities to perform their function. So if the 47 county governments can come together and they say they agree under that cooperation to form a joint cooperation, they can actually take an act to Parliament and they can establish something similar to that Health Service Commission that will be able now to take care of some bit of HRH. It doesn't even have to be everything about the management of HRH, but for the things that are actually taking us on strike, to get money directly for recruitment and where there are not these 35% ceiling, so that then we can get the welfare of healthcare workers looked at. This is something that only requires an intergovernmental coordinating summit to sit. They agree. And once they agree, they legislate to ensure that it has a structure that allows it to work.
But on the same breath, Peterson, you as the union leaders, if I may call you so, you're accused of wanting to force what you're saying, formation of entities, commissions, bodies that necessarily will not give us a solution that we need. Because the argument out here is that if we had a competent National Assembly, because you spoke about allocation, that's where money comes from, you would not be calling for an entity, commission or otherwise, because budget allocations would consider, when you're raising a budget, it boils down from the unit cost. We should be knowing how much does it cost to treat, to hire, to sustain, to improve a facility. Correct. And then we raise that budget accumulatively moving forward. And you time it. You say in the first cycle, second cycle, third cycle. So is the issue the incompetence of the people we have entrusted with our healthcare system? That the health ministry as is led and organized seems to have its priority mismatched, because the need out here, from what you're saying, you do have a need. You want to serve the nation. You want to participate in the growth and development of our humans, eradicate diseases, treat people, correct? But the person in charge is not accommodating that conversation. So instead of running, because even if you are given the 10 billion today, and it is misappropriated like many other trillions we are seeing in the country, we are going to have a same problem. Could the problem be the incompetence of the people who are in office?
You know, one of the pillars of universal healthcare or a working healthcare system is leadership and governance.
Right.
So that's one of the key things. But before going into that, I wanted to answer something that Dan asked earlier. That healthcare cannot be free. That it has to be paid for.
Yes.
If social health insurance or any insurance does not pay for somebody health care, then you must pay it out of pocket. That's the reality. And therefore, if hospitals give services, whether public hospitals or private hospitals, for them to be able to purchase the reagents, to pay the workers, to have the drugs, to have a working system, electricity and all that, they must be paid for. And that's why even in those insurances, there's always a timeline for payments and mechanisms to enforce these payments. And that's one thing which you must look into, that a patient who has an insurance, whether it's social health insurance or a private insurance, when they come to an hospital, they should not be denied care. But we must have a mechanism that ensures that the debt owed to facilities, whether public or private, are paid to ensure that people get the care. Because at the time that you are denying somebody that care, at any particular point, you are actually violating the constitutional right to access to the care.
Absolutely.
And sometimes we may lose lives that otherwise would have been lost. So you must have robust mechanisms to ensure that this is done. And that's why I agree with Peterson very strongly that some of the failures that we have been talking about emanated from the parliament. That when they are passing some of the bills that they did pass, they did not look deeply into those particular actions or those mechanisms to enforce some of these things, and even the budgeting aspect for it. So it is important that when we are having, or when we are going to these elections, we have people that will represent our interest. That really, when we have bills or acts being put into place, that those that actually are going to ensure that the health care, the education we need are taken care of.
And Dr. Atellah, we have to stay on that as just a little bit, because there seems to be a similar thread running through. Because if the mandate then is on medical facilities to offer up healthcare when they come, regardless, because you've said that UHC is not a phenomenon, it's a reality. So I show up to hospital, I'm getting treated. Whatever is happening in the back end as to how you're supposed to make that payment done is yours. But then the responsibility of medical facilities to offer this care, sure, but then there's also the responsibility of the authority to make sure that these folks are paid. It's the same idea. Like when you tell schools not to raise school fees, but you've not sent capitation to schools. It's a catch-22, because what do you expect them to do? And we can ask that question in its originality, because what do you expect them to do? So when a medical facility, as Peterson has approached, and they tell you, what, we're not going to offer it to you because we have a debt, how do you expect them to purchase these things that you're talking about?
My concern here is that you lie to a particular patient that you cannot give the services because maybe these systems are low when they're not. You have a contract with the authority that you are going to be giving the services. And it is through that contract that you should just indicate this has not been paid and is due. The 90 days contract, it indicates that you need to be paid within 90 days. Then when you fail to be paid, you offer services of 100 million and 90 days have not been paid, it means that the contract you have with the insurance authority has been violated.
Right. So when you offer a service and it's not
therefore
been
at that
paid,
point, when you don't go to the person you have contract with, which then has sent me, because I have contract with the insurance, I don't have a contract with the hospital. I have a contract with Social Aid Authority. I have a contract with Jubilee. That's why when I go to the hospital, before I'm given the service, the Jubilee or Madison or Social Aid Insurance must approve. So because they've already authorized me to go there. So here you have a contract with the insurance company, or with the insurance, the social insurance, but because you don't want to evoke the same contract that they're violating, then now you put it on this other person. So it is right that you tell us the truth. Speak it up, and that's what you keep on saying. Let the private hospital, the public hospitals, if payments are not done that are violating the agreed time, we must force these payments to be done.
So the problem is not primarily money then?
Yeah.
Because if this behavior of not paying on time, not communicating, or even just assuming that because they're hospitals and they have some medicine on their shelves that they're going to give the care, then you decide that you're not even going to talk to them. So it wouldn't matter if you had money. It's the behavior that is the problem.
But behavior must change by action.
So it's not the money issue here.
The behavior must change.
The
Behavior must change with action.
Badly.
You know, that's what I keep saying. If I go crying that I've not been paid by insurance, so I cannot offer these particular services, and I don't attack the person who I have a contract with, then there's a problem on me. I must tell the insurance company that you cannot have a contract with patients. You approve them to be sent to their facility, and then you're violating the contract I have with you.
Yeah. Peterson, so when these delays happen, right?
Yeah.
Not paid this facility, then as a result, every other thing is affected.
Yes.
Because then healthcare workers will not be paid.
Yes.
Reagents will not come to the hospitals. And
CBAs will be
CBAs
disordered.
will be disoriented.
Yes.
So at that particular point, I want to ask the question, if I have a contract with you for 90 days that you have violated, that contract ceases to exist.
Yes.
Because I'm not operating with you on any legal basis. And at that point, when that happens, that is the pinpoint where then Kenyans, like hospitals, will say, you know what, system is down. Because they don't want to tell you we have not been paid. So the overall problem when it comes to healthcare issues that do exist today is fact that managers of SHA or SHIF need to be sat down and understand the need of respecting agreements and contracts, because that will translate to Kenyans getting the universal healthcare that they do deserve.
The contract actually will continue existing, but it will be breached. And I believe it has some part on dispute resolution, how that is supposed to be addressed. But the reality is, you can address formalities and legalism policy. The reality on the ground is facilities fear raising their voices because they fear of losing contract because the insurer here.
What do you mean?
The insurer here is all powerful.
Hold on.
Yes.
We have a contract.
Yes.
Paper. It's not about whether you like me or not.
Yes.
It's paper. We have both our signatures appended to it that I'm going to offer a service. So you mean to tell me you violated the contract and then suddenly I'm afraid of you to come and tell you that
they have
this
fear
is how
that
people are operating?
It will not be renewed, and that is the truth of
you
the
see
matter.
what I said? Behavior. It's not money.
Where's then if that does exist, where is the promise of universal healthcare? Because that is what Kenyans will ask.
You see,
if contracts are not honored, you are afraid to speak to the other person who has that contract, then universal healthcare at that particular point doesn't exist.
And that is why it becomes easier for them to not take it on the patient. Please pay. Because I'm unable to address
which
the
then
person
becomes
I'm
unethical.
supposed to. It is very unethical, by the way. But the reality on the ground, it is unethical. But if I'm denied that service, I'll go home saying it's not working.
Of course.
But the truth is, it's supposed to work. It is that within that administration and the management of the system, there is a problem. And where is the problem coming from? As long as we are not getting enough money, so that we can be able to pay it on time. So that we are having delays. There are some administrative processes that you'll see that are in place to just delay so that we can have enough money to pay you by that time. Then we are going to get, we will be here discussing these issues until cows come back home.
So the reason
but the truth of the matter is we need to have enough money under SHA in all the funds, so that then people can be reimbursed on time. Our facilities will be working. They will have stocked their drugs, and I'm saying including the private. In the public sector, the counties, the national government can be able to chip in and ensure that there is that supply. They can be able to probably guarantee them, and they can get supplies from KEMSA and pay later because KEMSA is a government entity. But when it comes to the private sector, and I think we must appreciate the role of the private sector in healthcare delivery. I don't know if there is anyone of us here who takes their family to a public hospital, if we are to be honest. Most of the times, we may take them... Dr. Atellah wants to answer. We may take them some of the time, but a number of times, I'm sure even for Dr. Atellah, if he's honest, it goes to the private.
All my children avoid the public.
Because of the congestion, not because that we don't trust our peers, but because of the congestion that is in those facilities.
The public,
And so, the private facilities are the ones that actually suffer more because they don't have a buffer.
It's true.
And so, and that is why I'm saying this discourse, and especially the one that was happening at the summit and the town halls, is very good. And I wish we can have more of those so that Kenyans can come out and candidly say that you have a very good system. Ideally, it should work very well. And I've been saying this from the start. The way SHA is structured and the legal framework around social health insurance, the FIF and the digital health and the Primary Health Care Act, I'm telling you, it is the best. Ideally, it should work way better than NHIF. But then, NHIF had been in existence for how long?
60 years.
Long enough.
60 years. So, and this is a new system. So, if you were to compare NHIF at the third year or the fourth year and SHA is doing way better. Okay. So, one of the problem is because it's a new system.
I beg to differ.
Yes.
Respectfully. We cannot be saying that we transition from a healthcare system to a new one. And we need to have we expect some teething problems, whereby we'll be losing lives. Because remember, this is not a farming experiment. It's about people, and it's about health. Therefore, what was the planning committee? The conceptualization of the SHA, the first investment ought to have gone into how are we going to roll out this program? How are we going to transition? And make sure that we have one thing that seems to elude everybody who does all this planning, something called efficiency. That never comes up somewhere. So, in my opinion, I don't think we have that luxury of saying these are the early challenges, and in time, in years, you're going to catch up because we are losing people. Number two, it is sad that we are confessing that majority of Kenyans seek healthcare from private facilities because of the poor conditions that are existing in the public facilities. But that's a sad reality. But that is the sadder fact that the same SHA chief has not addressed the challenges that are existing in the public facilities. And therefore, the public does not have confidence. That's why you hear people saying SHA is not working, because not everybody can afford to go to a private facility. People will want to go to the nearest public facility, access quality health care. When they say it is not working, it is based on that premise that they are forced to pay more, the double taxation, the unethical charges, and still it is not guaranteed that the next time they make a visit, they'll afford it, or they'll even find a personnel in office, somebody could be on strike. This is a sad reality. This is the imbalance we are looking at. So how do we, Davji wants to say something,
I just wanted
how do we merge the reality that yes, there is no trust on the public facilities, SHA, we cannot afford to give it more time for it to work, and yes, the healthcare must be provided promptly.
When we say that the public goes to private facility more than the private, I don't think it's right, because the InfoTrack report, I think it was one of 2022 and 2024, indicates that about 72% of Kenyans first go to the public facilities, the dispensaries, the health centers, the level 3s and all that in the country. That's the reality. And that's because of also those facilities tend to have, currently and even before, there were no charges to the services. But then it also indicates that out of that 72%, around 51% will end up going again to the private, because once they go to those facilities, probably they may be sent to do particular lab tests to get the drugs out or things like that,
which are not available at the public
facilities.
So cumulatively, the number is more that ends up in there.
private.
Not the number is more. The number is about 2%, but there's some. I get the
If you
point.
want us to do the number,
So that is what the infodoc was indicating. But and the reality of the entire health workforce, what is it? The healthcare.
Yeah.
It's about money. You know, and I keep on saying, when we have the budget of the country of healthcare below 10%, and they have their budget declaration saying about minimum
At
of
least
15%, then you cannot expect the services to be as expected. And therefore, we go back down to the point of how can we allocate more money to the healthcare so that we can have annual employment of healthcare workers, doctors, nurses, clinicians, all into the facilities. Because the biggest problem of healthcare currently is not all these other many things. Because, I mean, we have been having a discussion of health financing. When you talk about SHA, it's just about health financing. When you talk about the NEP, it's about equipment in the hospitals. When you talk about infrastructure, the hospitals being built, the counties have built so many facilities. That means the access is there. The national government has decided to, has upgraded level 5 to level 6, and they're saying they're doing 13 more of 300 beds each. But then those facilities that are being constructed, those the equipments that are being put in those facilities, in those hospitals, and all that, they need a mixed skills of health workforce to ensure that if you go to that particular hospitals, level 2, 3, and 4, you get the care. And that's where things have gone really.
Doc and Peterson.
Yeah.
We talk about financing of healthcare.
Yeah.
And if you look at the idea around SHA is we contribute as Wananchi, right? But we look at the number of registered Kenyans, around 32 million.
Yeah.
But around 3 to 4 million are the ones who are paying. And with that then, this authority SHA is stifled of resources that they do deserve for them to be able to offer these services. So in this summit, how do we deal with that? Because at the end of the day, Wananchi who are registered must as well want to pay to access that. Because we'll say, okay, it has been allocated by the national government. But if Kenyans themselves don't pay to it, then services will not be received.
And that's what you were saying. But my line of thought before I answer you was that we need to have healthcare workers employed annually, the same way we do with the police, the same way we do with the teachers, so that because we're losing many nurses and many doctors and clinicians for across the country that are migrating. We have a lot of healthcare workers who have retired. But whenever counties are not employing, they're saying that the budget ceiling has gone down. So one thing before we go into centralizing health workforce, we need to see, can we have a ring-fenced fund just for employing health workforce across the country? That this is designed that that every, like now the 8.5 billion that was being given for the UHC, put in the equitable share so that it has the UHC within the counties. Then we have another 10 billion or 20 billion every year that ensures that we have employment of health workforce in the country. That's one thing that is very critical. And I think as a country, if you only look at brick and mortar and do not look at health workforce, it's something that is very damn. The other thing I wanted to say is regarding these private facilities, the difference with them and the public facility is that as much as with public we have taxpayers running this, in a private facility is a business. And therefore, you take care of the health workforce, you take care of the drugs, you take care of all these particular, of all the payments, all the vote aids. So whenever there is a problem or delays, the way they are affected is different with the way the public are affected. And that's why the conversations on how the reimbursement or engagement is done actually different. Even unions, the way we engage with private facilities where our members are is very different with the public sector.
Peterson, on the question of registered members vis-a-vis paying and how we bridge that gap, because we want funds to have a healthcare system that is working.
You see, the total number of registered under SHA is 20 what million?
32
million. But remember, there are dependents there. They are not all principal members. So not all the 32 million can actually be able to pay. So, but of course, we have many people, and especially who are not in formal employment, they only pay when they go to the hospital. And by the way, that is one of the biggest problems. And I think the president has been too kind because he has said that there will be no waiting time. I think from where we sit ourselves, we feel that waiting time was better to probably force these people to continue paying. Because what is happening, people are registering, but then they are not paying. And then when they fall sick, they will come and pay on the same day. And then they are going to, and then they are going to get the services, and they are going to be paid from the same fund. And so, how do we get these people to be committed to paying, to prepay before they fall sick? That is the biggest issue, because we have a number, we have a good number of principal members who are actually not contributing SHA, but then we don't have a modality to force them to do that.
Or as we wind up, should we consider having health what we call free but publicly funded?
It comes direct from taxes.
Be no deduction, just direct from taxation.
And
we resolve this.
That would be the best. I think that would be the best ideology.
Yeah, because you don't have to worry about
that's what is being
all
adopted with South Africa. That's what many countries have adopted. And there were this idea of waiting period of 3 to 6 months. There were so many Kenyans who will go to the hospital. You have already a condition and you are sick and you can't access the care, so you have to sell your land and all these things before you pay. But you see now with that's one of the things that actually are standing out in the SHA, that you pay, let's say 8,000 and your bill is 150 and you get paid immediately. So that's a very good ideology, and it has actually changed the insurance things in the country. We are seeing now the private insurance companies are also removing that waiting period, because it goes with the Article 43 of the Constitution that it's your right to access the care. It is not your really a problem that you are sick. It is just nature
that you should be able
and
to
then
access
it is a country. So with the social health, social insurance, you expect to seek the care as a role of the government. So, but the ideology of having a tax-funded healthcare, it means it relieves everybody. But this kind, can you talk about tax now the way we have?
I think a good idea. I think we have a solution here. Take it from one pot. And then you can apply it. Whether and it would be the same thing across board, from health to education to all of this.
Tax funded.
The time was too little.
It's
One
a
more.
conversation that is deep.
There's a lot to do. There's a lot to be discussed.
I've not talked about how my doctors are getting money.
No. You told us the country had. You guys are okay. You guys are fine. You got the money. I'm happy.
True.
But we have to end the
this
year.
is not only. It was doctors across the country.
You shouldn't say that when Kuko is here waiting for money.
But
you're telling us that you received your money.
There's something called farming. When you have a land, you're farming.
They are the
blue-eyed boys of the healthcare system.
You're tilling. There is what you call harvesting. So when there's harvesting time, you actually harvest. So we as doctors have been united and taking action.
So now you're harvesting.
And then we have a CB which was signed in 2017. It is true that it has been paid for 7 years. It is true now pay slips actually adjusted over 9 years. So that one has been done.
Okay, so now maybe we need now Kuko and the nurses to come and have a tete-a-tete with you and you tell us how it needs to be done. Welcome to his TED Talk. Thank you very much. Dr. Davji Atellah is the SG and CEO of the KMPDU. Peterson Washira is the National Chairperson of the Kenya Union of Clinical Officers. Gentlemen, thank you for being with us.
Situation Room, the only way to start your day.